All. This is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show, our first show of the new year. So Dr. Bill Murphy is with us today. Happy New Year to Dr. Bill Murphy and Happy New Year to everyone. Welcome, Dr. Murphy.
Thank you very much. Happy to be here.
So for the uninitiated who have not listened to your previous talks, tell us a little bit about yourself, and then I really want to dig into this anti-idiotype antibody and the neurological outcomes of long COVID.
So I'm an immunologist. I'm a professor in the departments of dermatology and internal medicine hemonc at UC Davis. I've been doing cancer immunology for about 35 years now. I was at the NCI for a while. And currently, I've been focusing more on the immune system, how it regulates itself, not only in cancer, but also in viral infections, because a lot of our cancer therapies were actually borne out on how the immune system attacks a virus. So there's a lot of parallels. And so my research lately has been looking at preclinical modeling and how do we make our models more reflective of the human scenario. And this is now looking at things like obesity and aging because that affects your immune system. So one thing that I've been a big proponent on is the immune system it's probably the ultimate in what we call personalized medicine. Everybody's immune system is so unique and it changes every day based on what we're exposed to and as we age and everything else. So we've been looking at our modeling to say, how do we actually see effects of either the cancer drugs, cancer immunotherapy, viral responses, even vaccine responses, and how do we make this more reflective of what we see in the population so we can use this more of a predictive on both the good and the bad. Because as we know with the immune system, too much immune system, you can get a lot of autoimmunity, toxicity. Too little, you get susceptibility to infectious disease. So that fine line and control that we've been looking at and trying to understand more of.
Got it. So thank you very much. And I'm going to very quickly share my screen to show the cool beans. This new paper that you have, or a viewpoint, potential role of anti-idiotype responses on the neurological effects of post-acute sequelae of COVID-19. So here the keyword being the anti-idiotype responses. So please tell us what this paper is about.
Yeah, and so originally, believe it or not, the title of the paper was on anti-adaptive immune responses or antibody responses. And this is for BBI, brain behavior immunity. So we were looking at the neurological components, and it was titled long COVID. And you're seeing now long COVID is sort of used in a lot of ways. And I changed the title to, you're seeing this more in the technical or the medical journals, PASC, because it's really sort of talking about all the different components. And when we're talking about long COVID or PASC, you're talking about a long-term effects after resolution of the virus, in which there's, it's pleiotropic, just like the virus. COVID is very unusual as opposed to say influenza and other viruses, where you can have circulatory effects, cardiac effects, gastrointestinal effects, and obviously there are neurologic effects because partly how it goes in, you lose your sense of smell. So there's a lot of connections there. So it's a very unique virus, and it looks like this long COVID wasn't really appreciated. It's getting more and more appreciated as a real syndrome because it was very difficult in the era when you still have continuous exposure to the new variants. So you can be continuously infected. You can have rebound COVID. It was really difficult to say, is this really what we would consider a post-infection sequela as far as something that's keeping it going as far as the pathology, versus you may have a subclinical or continuum or new infection, and that's what's actually doing it. So it's been very difficult with clinical samples, but I think people are realizing now people are having symptoms well long after, months and months afterwards. And so the whole point of this article was a lot of the research on long COVID was mainly focusing on the increased inflammation and biomarkers of inflammation. And as an immunologist, we know that usually inflammation is triggered by something, either a pathogen or an insult, but to maintain it, you have to have something that is also maintained. And probably the thing that is the most long-lasting would be in an adaptive immune response, a T and B cell response, which for most of us can maintain for the life of us. And so, which is good and bad. It's good in the sense we can have long-lasting immunity, but it's bad in the sense if it's autoreactive, it's hard to stop. And so the whole point of this article was that, there's been so much looking at long COVID from the standpoint of what we're correlating it with, but the question is what's causing it? And so the idea was, is there an adaptive or long-lasting immune response that could be constantly triggering these inflammation responses? And so the whole point was maybe this is an anti-idiotypic response, which I brought up in my New England Journal paper, in which an adaptive response is initiated that is initially protective to the virus. So if you look at this diagram, when you have COVID-2, which is the virus there, a productive immune response is what we call an idiotype response. That's AB1. That means we're making immune responses to this foreign pathogen. Now, there's different antigens on this virus. Antigens means anything that the immune system can see is different. Now, the emphasis has always been on the spike protein or the mechanism by which the virus enters the cell, but there's numerous other antigens that also exist that the immune system responds to. The problem is that from a vaccine standpoint, most vaccinologists for the viruses usually will go against what the virus uses to enter the cell as a way to block it. The reason being, it's usually the most accessible, but also it's a 2-for-1. Not only can it bind the virus, but it may also prevent the virus from actually binding and entering the cell. So that's why it's a very logical candidate. The problem is, though, because it binds the cell, binds the particular proteins on the cell, and in this case with COVID-2, this can be the ACE2 receptor, but it also NRP1. That most people don't talk about NRP1, neuropilin-1. It's also on cells, neuronal cells, as a matter of fact. And it could also potentially mediate internalization in neuronal tissue, but therefore also maybe it could be something that induces an immune response as well. But for the most part, the emphasis has been on ACE2 and with spike. And so what we find is, as an immunologist, what turns off an antibody response? How does the antibody response, how do the B cells know to stop making antibody? And so Urnay in the 1970s proposed this, what we call the network theory, in which antibodies themselves are also immunogenic. That means they're also different, and we can make antibodies to the antibodies. And he proposed what we call the network hypothesis, in which these anti-idiotype antibodies, or AB2 antibodies, are made to bind and then turn off an immune response. The reason being, if there's no more antigen, you don't need these B cells making these antibodies, and you want to turn them off. And so the anti-idiotype response was viewed as a way of control. It's a way to actually dampen a response because the immune system needs to turn off. It's always big on turning off. And so the AB2 responses, the anti-idiotype responses, will bind, and this is, and it's been thought maybe this is why when people get vaccinated, if you keep vaccinating, it starts wearing off, and you actually don't see increase, you see more decrease. And in fact, COVID-2 is known to have very short-lived antibody responses to the vaccines. And so the idea is this anti-idiotype or AB2 response normally is going to just block the AB1. However, if you look at it, if you can look at my hand, okay, so let's, if you can just focus on my hand right now, it's a little bit easier. Let's assume that this is the spike protein. And then we make an antibody to it. So here's the antibody to the spike protein. Now, what's going to happen, this area, your immune system can make a response to in this antibody. And that antibody will look like this, some of them, all right? And that's what we call a mirror. It mirrors the spike protein because it binds. So now this antibody, AB2, you can go back to the diagram if you want, this AB2 antibody has all the ability of the spike protein, okay? And it will bind that, what you can see in that's the yellow antibody, the AB2 is binding the ACE2 receptor because the spike protein binds the ACE2 receptor. And it's already been found in COVID-2 patients. They can make antibodies to ACE2. And that's not a good thing because ACE2 controls a lot of physiologic processes, including inflammatory, cardiovascular, hematopoietic. And so this is not a good thing. But some of these anti-idiotype antibodies will bind ACE2, and they can do many effects because of that, and they're not necessarily good effects. Now, not all the anti-idiotype antibodies are going to bind ACE2. Some of them. It's a multi polyclonal response. But it's already been shown in other viral pathogens and other disease states, you can actually use this anti-idiotype antibody as a surrogate antigen. People have actually made monoclonal anti-idiotype antibodies and they've immunized animals and they can get protective responses. So it actually works as a surrogate antigen, but also it can mediate some of the spike protein's functions. So one thing that people appreciate more and more is the spike protein is not just a passive way to get into a cell. The spike protein has a lot of really potent inflammatory effects by itself. It can trigger toll receptors. It can mediate a lot of functions on its own. That means these anti-idiotype antibodies may be able to mediate some of these same effects of the spike protein. But not only that, they do other things that the spike protein can't do, because an antibody is made to clear cells. It's made to kill cells. And so this is where you see that antibody-dependent cell-mediated toxicity that you see, the elimination of the cell. Because normally the antibodies will bind, that's how we use them in cancer. They'll bind the cancer cell and the cell gets depleted, gets killed. Well, these anti-idiotype antibodies therefore can potentially bind ACE2 positive or NLP1 positive cells, causing either their clearance by ADCC, but also it can block normal binding. That's the antagonist function. It blocks ACE2. It can also cause the ACE2 receptor to get internalized. So all of these things are going to cause dysfunction. Now, the bad thing about this is everybody is going to be different. Everybody makes different antibody responses. And some of these anti-idiotype responses may be perfectly harmless. Some of them may just clear the idiotype response, but some may actually mediate effects. So the point of the article is these antibodies, anybody that has autoimmunity knows it's long-lived. It's very difficult. And the key component is that antibody responses are made by what we call plasma cells, which are B cells that are long-lived and they reside in the bone marrow, and they're very hard to get rid of. Working on B cell leukemias and lymphomas, I can tell you that myeloma, which is a plasma cell cancer in the bone marrow, is one of the more difficult ones to actually get rid of, because as opposed to other B cells, it's hard to actually deplete these cells. And same thing with autoimmunity. So in a sense, this anti-idiotype response is like an autoimmune response that gets induced. The problem is every time then we vaccinate to spike, we can now further amplify this response. All right, because again, the immune system is trying to turn off. It's going to make more anti-idiotype. And that's been shown in preclinical studies. And so the whole point of the article is that, and there's another caveat. The other caveat, and this is very important, is everybody is so CoV-2 centric, CoV-2. Well, there's the endemic coronaviruses that have been around for 100, 200 years. These are what we call the common cold, upper respiratory infections by the common coronaviruses. NL63 is one of these. Its spike protein also binds ACE2. All right. And so that means that anytime we get a common cold by some of these other coronaviruses, we could be inducing these cross-reactive responses further. So it just keeps amplifying. So the problem is, I think, in my mind, that we need to figure out how much of these anti-idiotype responses are playing a role. And there have been now some papers coming out, clinical papers, showing in long COVID patients, after vaccination, higher anti-spike protein responses, but also this one paper just came out, ACE2 antibody responses after a vaccination in patients with long COVID. And so I think it's the kind of thing where the immunology, unfortunately, is sufficiently complex that, and there's been no preclinical studies really looking at this. And that's been a big problem, is that you have to have an initiative. You and I were talking about, I work on CAR T cell therapy for cancer, and what we have to do to get this into people is amazing, the amount of studies, preclinical, before we can actually put a new one in. And yet with the vaccine, for the most part, 90% of the studies just focus on antiviral efficacy in the beginning stage. There's no long-term studies, no looking in obese animals or aged animals or pregnant animals, and no looking at cross-reactivity. And that's been a big problem. So I think the other thing that we have to start considering is that when we're doing these repeat vaccinations, we need to figure out what are some of the off-target effects. Now, there's another paper that came out in BBI showing in long COVID patients there are antibody responses to common tissue antigens. And so we have to be careful. It's not just anti-idiotype. We can also have cross-reactive antibody responses that also get triggered. So, and everybody is different as far as autoimmune susceptibility, and therefore what kind of antibody responses you're going to get. But this is basically the point of the article, is that we need to do preclinical studies to actually see if these anti-idiotype responses can mediate some of these long-term pathologies. How are they induced, and how can we control for them? Because up to this point, most of the treatments for long COVID have been pretty much symptomatic or just global suppression. And that, just like with autoimmunity, doesn't work very long. All right. And so I think that's what we're going to have to start looking at. And then finally, the other point of the article was, as we get older, we rely more and more on these cross-reactive secondary responses. Our immune system starts to shut down from T cells as we get older. And therefore, at my age and on your age, unfortunately, we have mainly what we call long-lived memory T cells. And same thing, these cross-reactive responses to the common cold viruses like NL63 and others get first activated before we can make a new response. And that means we have a greater chance for cross-reactivity to ACE2 and other kinds of receptors.
Interesting. Thank you so much for this explanation, because I see anti-idiotype antibodies ignored all over the place, and I think it is a very important thing. I have two questions. One, when you're talking about the anti-idiotype antibody production,
Yeah.
you mentioned that it is possible that because the responses are polyclonal, there may be one that can bind with ACE2, but there may be antibodies that might cross-react with our tissues.
Right. And so that's the thing is, we have, most people think the antibodies are so specific, and they are in a way, but they're only seeing a small part of that protein molecule. And so sometimes out of context, it may cross-react with others. And so it's the kind of thing where that's why a polyclonal response is so important, because you're looking at all of it and your net effect is it's very specific. But one monoclonal can maybe see this, and that may be also something that's that little amino acid sequence may be similar to another totally unrelated kind of tissue antigen that we didn't expect. All right. And so these are some of the things that we're seeing just in general that you have to be careful about. And you mentioned about anti-idiotype response as just not really being looked at. The problem was that field of study was mainly in the 1970s, 80s, and 90s. And it was very exciting. But for the most part, a lot of times it's really got to be proven as far as how do you prove it in people, and then how do you exploit it. And so for the most part, it hasn't really been looked at as much, and you don't really even see basic textbooks covering it. I think this will cause a resurgence, because I think we're realizing, especially since we're seeing in the aged, and that's the other thing, anti-idiotype responses seem to increase higher in older animals because more regulation at play. And I think that's where we're going to start to see a resurgence and why this should be looked at.
Understood. Thank you very much. And then I have the second question. In this paper, let me just very quickly show it to the audience as well. This is the paper. You have specifically focused on neurological outcomes.
Right.
Is this necessary that the anti-idiotype would only be implicated in neurological outcomes, or
No,
it
no,
could be
not at all.
broader than that?
It was just, this was the journal that it's focused on neurological components. And actually, some of the cardiovascular and the thrombolytic and the hematopoietic components are probably contributing to the neurologic components too. So this is something where it's a general concept for all aspects of long COVID. Because of the journal was focused on neurologic, I emphasized, and also because most people don't talk about neuropilin 1, which is on neuronal cells and CoV2 combined. That makes it even more attractive as far as saying it may play a role.
Understood. So one more question. Can these antibodies cross the blood-brain barrier and end up in the brain and affect there, or this is peripheral nervous tissue?
Usually, antibodies don't cross easily. However, as you undergo, as you age, you become more, there's more of a meta-inflammation. Obesity and aging cause what we call meta-inflammation. And anytime you have this kind of inflammation, you're going to have what we call more of a leaky vasculature, more, and so things can get in. The other thing is, as you get an infection or you get sick, this is also causing inflammation. So as a rule, the antibodies will not cause cross easily. And maybe that's why some of the symptoms are more peripheral as far as weakness, fatigue, and joint and muscle pain, things like that. But CoV-2 is also different. The other thing that's very important to note, and you mentioned this before in your short, and I got to admit, I was skeptical because at one point you mentioned that people are seeing the spike protein and the virus lasting for months. And I was skeptical because as a biologist, as an immunologist, things usually, unless you're replicating, they degrade. And yet there have been some papers showing that for some reason the spike protein and virus, at least by picking up by RNA, can be detected for a long period of time in people that are not acutely infected. And I mentioned it in the article that this sort of breaks the paradigm on viruses as we know it, because usually when we think of viruses, we think of acute viruses. All right. In other words, you get a cold, you get a flu, you get sick, your immune system attacks it, it resolves and goes away. However, there are types of viruses like EBV and CMV in which you get infected and they become what we call latent and they stay with you, or herpes viruses, and they can stay with you and they can get reactivated, but they're with you. The other coronaviruses, what COVID-2's in, are usually considered more, they're not latent. And yet COVID-2, they are picking it up longer and longer. The problem is, again, they're relying on clinical studies. And because of variants and because of the high infectivity rates, it's hard to really pin down, is this really a continuous virus or are you just getting an asymptomatic new virus? All right. And same thing with some of the vaccine approaches.
So if you give me a minute, we're talking about your paper. I want to show you a study that actually is on the same point as you are just saying.
Mm-hmm.
I actually just recorded this study. This is 22nd December 2023, so pretty recent.
Mm-hmm.
Predicted risk of heart failure pandemic due to persistent SARS-CoV-2 infection using a three-dimensional cardiac model. So here, it is an in vitro study. But what they found was they infected the cardiac tissue, human cardiac tissue, with the virus, and what they observed was infection occurred, the virus was observed, then it went away.
Right.
However, 28 days later, when they exposed the same tissue to hypoxic condition, all of a sudden, the virus spike protein started co-localizing with the cardiac tissue again, and troponin got produced again, and the ACE2 started forming again, which apparently the cardiac cells had actually recovered.
Yeah.
But as soon as the stress appeared, the virus reappeared.
Yeah, and that's actually kind of scary. It means, and that's a paradigm shift as far as the idea of a latency. Now, it may be that the other coronaviruses, because nobody's really looked at the common cold viruses, right? As far as usually there's always let's say, the amount of money and science usually goes into the severity of the disease, right? And the common cold, people say, we can't make a vaccine to the common cold because we've always been exposed, but it's never really been rigorously looked at. Maybe coronaviruses can become latent, and that's why they're so endemic. And maybe it's going to be a matter of viral load or immune suppression or something like that. But it's an interesting concept that I think we may have missed with the less severe upper respiratory diseases, but maybe COVID-2 is illustrating this is a potential. And if that's the case, and we don't understand enough on how that works, because it's not classically, like I said, with the herpes viruses or EBV, CMV, what we think of. But it's definitely going to be a potential problem because clearly people get colds every year, right? Now the question is are they really getting a new virus or is it basically coming back? If COVID-2 shows this, that could be troublesome because it also means, is our immune system controlling it, and does it change at all during that process? Because viruses always adapt. So that could be an interesting thing.
So then I have a question. So
Yeah,
here is the question. Considering this study and considering autoantibody paper, that this is your second paper on this topic,
hmm,
maybe there are more, but I'm aware of two. So imagine, just like you said, with the repeated vaccine doses,
right.
we continue to increase the chances of producing more and more of these autoantibodies, and that means more and possibility of more cross reactivity with every dose. If the virus latency is also a mechanism, and this is not really reinfection, this is a virus, SARS-CoV-2, sitting in the cardiac tissue. Apparently cardiac tissue has recovered and the virus is dormant in there, and
Right.
then the virus becomes reactivated under stress. Would it mean that a person who may have the latent virus would continue to have reactivation and phases of development of autoantibodies every time they undergo
It may.
stress?
You can create almost any scenario. You could also equally make the statement that the vaccinations are keeping the virus latent because it's inducing the protective responses also. That's how vaccines work. And so it's
Hmm.
very possible that you can get the positive effects. And maybe that's why the clinical studies are so confusing, because in a mixed population, you may be able to see, as I showed you even in that figure, some of these anti-idiotype antibodies may actually also activate the ACE2 receptor. That's where it would go on the bottom. It says antagonist, but some can also be triggering. All right. And
Agonist
so,
over here.
yeah. And so, in that sense, and it's going to be the net effect. So, everybody's antibody responses are different, yours, mine, everybody's, and what the makeup is. Some could be positive, some can be negative, some can be mirror images, some may not. And it may not be the only mechanism. It could be a factor that augments, it could also be a factor that triggers, but it's definitely more complicated because, also, as you mentioned, the spike protein itself has a lot of direct effects. And so, so when you have something that has direct effects, so that's the other thing I'd never thought about before, as I always thought about the anti-idiotype response binding the ACE receptor. All right. And people are seeing that. But if the spike protein also triggers inflammation, well, that means these antibodies may also bind the toll receptors in such a way and trigger inflammation, non-specifically. And so it definitely creates a complicating scenario. And there's probably almost no way with clinical data to really tease it out. All the studies that I've seen are just sort of like, yeah, we see higher levels, but you can't do in clinical studies because of people exposed to different things, different immune systems. You have to do preclinical, and yet there are no initiatives by the NIH to actually even do these kinds of studies, which I always find shocking and very dismaying, actually, because if this was a cancer drug, we would be tearing it up. If you have even a hint that something could be carcinogenic or have an outward effect, you have to go through all these hoops. And yet, clearly, these are possibilities. Now, I'm not saying that this is the dominant pathway. Just like we don't know about the longevity of the virus, and I mentioned in the article, because it's been seen in some patients for a long period of time, we don't know in the general population how predominant this is. All right. And you really need to have some virologists that really know about viral latency and activation to tear this up. This is just a new paradigm that I think may be contributing, and it shouldn't be taken politically pro or anti. It's just the kind of thing if you understand the immunology component, there's nothing either good or bad, but thinking makes it so. That means the immune system can do both at the same time, and it's your net effect, right? So we're still protected
Understood.
by the virus, which is good. It's just going to be a matter of, do we now to understand some of the long-term effects?
Absolutely. And in medicine, we do that for every intervention. We say, what are the indications? What are the benefits? What are the side effects? What are the toxicities? How do we fix the toxicities? And even everything that goes out in production, we call it phase 4. So it is part of the science to keep looking at side effects as well.
I think the
Nowadays, it's
problem
a weird,
was, yeah, the problem was, I think, because of the urgency. And that's always
yeah,
been the issue. Because of the urgency, it was so accelerated that it really jump started a lot. And it's very difficult to go backwards. Once the genie's out of the bottle, it's hard to go back and say, oh, we coulda, shoulda, woulda, right? And it's very hard because of the urgency, because it was decimating, the whole population. But at the same point, I think there's a denial component now on, well, it's done, let's move on. But that's not the case. I think we still need to understand this because this is now a permanent facet. Both how we treat it and how we're exposed is now a permanent aspect of our society. And we can't just say it's all better. There's a new wave going on right now. So the bottom line is it's here, and we need to understand more of the ramifications. And it's through preclinical studies that we can actually take away some of all these variables. The beauty of working with mice is they haven't been exposed to the virus or EBV or CMV in the past, and it's only what we're putting in. So I propose that we need to be giving anti-idiotype antibodies to in these animal studies to see, does it mirror this? We need to do vaccine studies and see, can we see this? Until then, you're still relying anecdotally on huge outbred population where you can see almost what you want to see.
So that's scary if we don't do these studies. And I have $1 million question with you, for you, and that is, how do we fix it? There are so many people with neurological outcomes.
Right. Yeah,
How do we fix it?
it's very difficult. There's there are autoimmune conditions where you have, especially among some of the elderly, where they have this chronic neuropathy and degeneration. And it's not just that. When you even things like dementia, it's the kind of thing where you're looking at as we age. We're in an aging society, and we're in a society that's more and more obese, which is increasing the inflammation and the aging components. And so I think there's almost like a multi-pronged approach. One, we have to do preclinical testing mirroring our population. The majority of preclinical testing, even in cancer studies, use very young, healthy laboratory mice that are genetically identical, which is not the human condition. We need to be looking in older animals because in fact, I had seen in some of our studies, some immunotherapies, I think I mentioned before, in young mice were fine against the cancer, and obese or aged mice, they died within cytokine release syndrome within hours, which mirrored the clinical scenario. And yet there's a reluctance to show negative data. And I think part of the problem is too with COVID-2 is the politicization of it. It's politicized so much. I am an immunologist. I'm not pro or anti anything. I think the vaccine is tremendous. It was needed to actually prevent death. But at the same point, it cannot be unless you're going to tell the population we are really researching everything about it, even after the fact. All right. Then unfortunately, it's going to be a level of mistrust or even viewed as one way or the other, rather than objectively saying this can do this. And it may be the anti-idiotype responses are not the major component. It may be they don't really even do much, but it's a theory that still is plausible and needs to be assessed. You can't just armchair science it away. You got to do the studies, and you got to do it right. And so that's been a big problem, even with the FDA. A lot of times we will do studies that do not show negative effects. You can gear anything up that way. You can see what you want to see. Just like I mentioned before, in my cancer studies, I can cure cancer in the test tube many times. But as we get more and more complex, it gets more harder, right? And so it's a matter of we have to go back and do the studies. They have to be incentivized, and they have to be encouraged. It can't be just poo-pooed as can't happen without doing the data. All right. And I think we have to figure out, because the other thing is, just like with chronic fatigue, long COVID, you're dealing with a lot of multifactorial components, a lot of subjective criteria. Cancer, in a way, is easier because you can see the pathology. You see the tumor. You can see it shrink or not. With an autoimmune component, it's so difficult. And then when there's a neurological component as well, then you're relying on just almost like 1960s and 70s, global immunosuppression. We still do intravenous IG, just IVIG and things like that. And we need to understand more of the sophisticated immunology of what could be going on, even if it's looking at a more simplistic animal model.
Understood. So, can I conclude this part of your
Yeah.
message, and maybe a little pessimistic, that even when we know there are multiple mechanisms going on that are contributing to long COVID or vaccine injuries, we actually do not have enough studies to figure out how to fix this.
We don't have any studies. There's no preclinical studies that are being initiated. In other words, we need to be figuring out how to turn off these anti-idiotype responses or even cross-reactive. And we have to make our preclinical models more relevant. So in our preclinical studies, like I mentioned, we use genetically identical mice that are kept under super clean, specific pathogen free. They haven't even seen any kind of viruses. That's not humans. And so anything that could be cross-reactive isn't being mirrored. So we need to understand how so we can't look at COVID-2 in a vacuum. COVID-2, just like the other coronaviruses, are working together. They're actually similar, and some of them bind the same receptors. So that means your immune system has already been geared for that. All right. And so we need to understand what these cross-reactive responses are doing. And that's something nobody's really, there have been some papers in mice where they've seen these cross-reactive responses actually affect vaccine responses. And so it clearly can play a role, but we have to model it better.
Understood. Understood. I hope that there is more funding and there is more encouragement, as you said, for these kind of studies. I actually find it very interesting that even those studies that may be pointing out that there may be a side effect worth looking into, even they try to kind of hedge their bets and put in the words and sentences that give them cover so that they can continue to get published. But I
Yeah,
think there should be a very open discussion and
the
looking at
problem is,
positives and
yeah,
negatives.
I think if you look in the history of the literature, one of the big issues that really hurt the field was the Wakefield incident with autism and vaccines, which was turned out to be a lot of data that was, I guess, not real, and it really polarized, the whole vaccine component, and I think that it made it very difficult for immunologists to even want to go into that foray, right? And so originally, when I wrote some of these articles, I have people that work in the area and say, I think this is great, but I don't want my name on that paper with you because of the backlash, and for me it's easier because I don't necessarily work on some of these neurological components. I'm working more on the cancer component, but like I mentioned, the immunology is still there, so it needs to be at least raised. But it's such a political issue that it makes it very difficult even to discuss it, because it's always viewed as, are the person raising this, are they being sensationalistic? People are going to grab on to snippets of it and take it out of context. And that makes it very difficult even for the scientists to even want to dip their toes into that foray. But I think this is something that is so global because it's the whole population. And that's what makes it difficult too, because the original vaccine studies now, how much do they actually play any kind of role? Because we're now on our third, fourth generation vaccine. That's a different product. And so therefore the playing field is changing constantly. And that makes it very difficult. Just like how do we vaccinate? Do we give all the vaccines at the same time? Flu and COVID? It's not based on really robust preclinical studies. It's based on sort of a gestalt. And that's something that everybody's gone to the one way of just trying to reassure. But if you're going to reassure, then you have to be just as diligent in doing the research, regardless of what the answers are. And that's what I'm
Understood.
not doing.
So I want to show you something.
Mhm.
Uh, same thing that you're talking about. So this is a beautiful study that came out. Actually, let me show you the study. I was presenting it to you before the talk as well. So it
Yeah.
is published in Nature. N1 methyl pseudouridylation of mRNA causes +1 ribosomal frame shifting, December 6. Beautiful study. What it is saying is that the ribosomes are slipping on these methylated uridines, and because of that, there is off-target, or as I call them, garbage proteins formed. However, when I was looking at the article about this, they said this very interesting uh, uh, wrote this very interesting thing that kind of makes me wonder. So they said he added, so Dr. James
Yeah.
Thevanthiran from the MRC toxicology unit, he's one of the co-authors or lead authors. He said, he added, we need to ensure that mRNA vaccines of the future are as reliable.
Right.
Now, when we put the word, just this tiny little word of as reliable, what we are saying is we should do something different to the future vaccines, but hey, they should then become as reliable as today's vaccine. Then why are we making any changes if they are,
Right.
because if we already have a
Yeah.
reliable vaccine?
And I think that's the problem, is it we've gotten so careful, we actually then dilute the message so much, the message is lost. And I think this is a very important article because it's showing that RNA vaccines are not like what we would consider our classical vaccines. We can't regulate how much each cell is making, where they're making, and for how long they're making it, and everybody's going to be different. Versus if I just put a protein of a defined amount into you. And so I think, and now that we, with this paper, this is important paper because it means that also we can't assume just because we're putting this gene sequence in, that's all that's coming out. Now, it may be just like with the anti-idiotype response. It may be that this is perfectly harmless. It may be that maybe 10% doesn't do much. But again, we don't know really the real frequency. And we don't know what these other protein responses are too. But because we are seeing antibody responses to other tissue antigens following CoV-2 and other things, it's quite possible that's also how CoV-2 also can exert this kind of an effect. And it's a masking system. You know, again, viruses are very good at evading and masking. And so when you have that kind of instability, then it raises a whole new kind of concept on, well, then how much do we need to have to know before we consider it completely safe and we know about it, knowing that everybody's immune system is different. And so that, and then 10%, and you call it garbage, is it certain types of garbage? Is it basically, and then how cross-reactive is that? And so that's still something that is very important to start to understand. And I think you're going to see a backtracking where people are going to have to realize with these RNA vaccines, they can be made fast and cheap, and they can be adapted easily. But some of the basics we still don't really understand yet. And so that's the thing that I find surprising, that there's not more of a, I don't know, not uproar, but just more of why aren't we learning more? And that's disconcerting.
So I had on this topic, I had a discussion with someone who is very, very much pro-vaccine, and
Mhm.
so there are. I am pro-vaccine as
I
well,
am too.
but
I've
I also
gotten,
talk
yeah.
about side effects too.
Hmm.
And when I talk about side effects, then people call me anti-vaccine, which I cannot
Right,
understand why
right,
this happens. But I was talking with someone who believes that vaccines do not have any side effects and there is no possibility of any problems with them. And what was interesting for me was that they were not open to any studies to understand if there could be a side effect. And
right,
their message was billions of doses are given. That in itself is a proof that the vaccines are fine and we should just move on. I
right,
thought we should say billions of doses are given. We, whatever was the reason, there was a time that it was needed, so we did it. Now we should go back and study and see what happened, what good happened and what not so good happened, and collect that data instead of dismissing it all to say, well, billions of doses, we should
right.
move on.
I think there's a problem, and I hate to fuel the fire, but when you have companies that are making that, and they're the ones that are providing the data, and they're the ones that are fueling the advertising in the market, it makes it a little bit more difficult to figure out, you know, how retrospectively to figure out what maybe was not optimal or what could have been a side effect. And so you will get that. And unfortunately, there was also the campaign, because of the political nature, where people were either you're pro or against. It became very difficult because I'm just and also immunology. What we talked about now, the idiotype concept, that is one of the more complex concepts in all immunology. I still have to talk to other professors in immunology and explaining it more because it's very, very, it's like ripples in a pond and knowing about affinities and, and so people think they're armchair immunologists. And so they say billions, but yeah, we know everything can have a side effect, everything, even water. And it's just a matter of understanding the immunology as far as potential, because clearly some people are getting afflictions. Some people are having long term effects from the virus, which is going to do the same thing. So the anti-idiotype component is not just for the vaccine. The virus itself is doing that, just like the other coronaviruses. So it's in our best interest to understand how these viruses have evolved to amplify an immune response, because the virus wants an anti-idiotype response because that suppresses its immune response against it, right? And so it's the
Yep.
ultimate evasion. And so those are things that I think it's people I have a hard time understanding that, and therefore the models are complicated, and they use these devil's arguments. Well, so many, and it's like there's nothing underlying that that's scientific. It's just a gestalt.
Correct. And just to demonstrate that science can actually look at both sides and be okay doing that, here, when I was presenting you these various studies, this study predicted risk of heart failure pandemic due to persistent SARS-CoV-2 infection using a three-dimensional cardiac model. This study is saying that the virus is so bad that any stress on the heart can reactivate it and cause further damage. This is not about vaccine, this is about the virus. And here is another study that shows that the vaccine can become bad. And
Yeah.
science and scientists have to be able to look at both sides and see what is happening and learn from this and improve.
Well, I mean, clearly we're using the same part of a virus. We're thinking what we're using is the good part, but it's also something that the virus uses, and it's a bad part. And so
Correct.
anything that the protein that we're making can do, the virus is already using it for a reason. And so we need to understand that, because that's going to have some effects. And then the immune system components are also an added effect that we need to understand as well. So I think those are the things that, unfortunately, again, you have to incentivize that we can do these studies, but the scientific community is actually, I think, and I can understand it, because you can get threats. I don't,
I get death threats.
yeah, I don't follow. I don't do this all this media stuff at all. So ignorance is bliss. But I think that that's the problem. And then also, it's interesting. I'm at the tail end of my career, so I don't really have a lot that, if I was in a beginning stages, I wouldn't go near this with a 10-foot pole
Hmm.
because of all the backlash. And I see it within my friends that are in the autism researchers. They're still
Hmm.
trying to figure ways to walk that fine line, because people can get so polarized. And I see that even with cancer patients. They're very informed, but some, just like with anybody, they'll anything, they'll latch on to. What about this? What about, And so you have to be very careful as a scientist that you don't get sucked into that, almost like a bandwagon.
Understood. So, with this, thank you so much. I'm going to very quickly look at the comments here if there is any question here. But in the meantime, thank you so much for being here. Thank you for giving us time right in the beginning of the new year, and really appreciate your insights. And
Well,
congratulations for this paper.
thank you very much.
So, thank you very much. And I would hopefully see you again.
Okay, take care. Hope everybody does well. Bye.
You too. Bye bye. Cool beans. With this, thank you very much. I would see you again tomorrow. I have some changes that I want to propose to the topics that we will do. But please give me a comment. Uh, there is one set of topics that I am still very much, um, I am still very much convinced that we should talk about, and that is studies of long COVID and vaccine side effects. And so I want to continue to do them. But in addition to that, I want to move a little more towards medical lectures too. And in that, supplements and lifestyle choices is another area that I think is important for us. So give me your comment. I would discuss that in detail again tomorrow as well. Also, tomorrow the YouTube lecture will be 10 a.m. in the morning because I have a guest who's joining us from Britain, and my morning and their evening is what will work. So thank you, and I will see you tomorrow. Bye for now. And in the meantime, please like, subscribe, and share, and get access to Dr. Bean. The link is present in the description. Bye-bye.